colostrum. This is liquid gold, and we could sell this to bodybuilders. True story, they pay a bunch for that, but let's give it to our babies instead. Hello and welcome to all of you beautiful birthing people. Welcome back to the channel. My name is Elizabeth, also known as Nurse Zabe, here on YouTube and Instagram, and it has been a hot minute since I have uploaded a video. So I'm hoping to kind of get back in the swing of things, but unfortunately I am like well off of the YouTube algorithm. So if you could like, comment, share this video, that would do loads for me. And without further ado, let's jump on into it, y'all. So today's video was actually inspired by somebody over on Instagram. I posted an Office clip or something about The Office because I love The Office. It's near and dear to my heart. And I have a reaction video on Pam's labor and delivery and birth two-parter episode. So I've got two videos on that if you want to go check it out. But in that, basically, Kelly is saying like, oh, if you have a cesarean birth, they take out all of your organs and put them on a table. And I would not want that to happen to me in her typical Kelly fashion.
Did you know that labor can last weeks? And they take your insides out and they just plop them on a table, and sometimes epidurals don't work. You can poop yourself.
And somebody messaged me and was like, hey, is this true? And I was like, you know what, it's not true. And that makes me want to do a labor nurse bust some myths about childbirth, pregnancy, all of those good things video. And then I realized I'd made that video 2 years ago. But I've come up with 10 more myths that we're gonna bust together. So back to that first myth that they heard on The Office, that when you have a cesarean birth, they cut through 7 layers of tissue, fascia, muscle, uterus to get to the baby, and then they take baby out, and in the process they take out every single one of your organs and they put them on a table. The fact of the matter is that is not true at all. And in fact, your organs are not in front of your uterus. We have our uterus growing and growing and growing and growing and getting the size of a freaking watermelon. It is pushing your internal organs, your stomach, your lungs, your intestines up out of the way. So all of those are actually up here, and then your uterus is right here. They don't really want to touch any of your other organs. In fact, they're very careful to make sure that they are not touching the bladder, because sometimes that bladder and uterus can kind of be attached to each other. They're like BFF buddies. They're very careful that they're not messing around with your intestines. And so they may, depending on the physician performing the surgery, how your bleeding is looking, what else is going on, take your uterus out to manually massage it outside if it's bleeding a lot, but not every provider does this. So they do not take all of your organs out. The next myth that also I see a lot on TV and in movies is when your water breaks, it is big and dramatic and the start of active and intense labor. That's simply not the case. So for some people, water breaking does occur before contractions occur. For about 10% of people, your water actually breaks before labor occurs. But then labor will either sometimes start quickly, but often it'll take a little bit of time for labor to start after your water breaks. For most people, about 80% of people, in the first 12 to 24 hours after their water breaks, labor will take place on its own. But another thing about the water breaking is it can totally be a dramatic gush of fluid. And we call that like a gross rupture of membranes, just meaning that it's large, not that it's nasty. And what that often means is that the bag of water that's sitting in front of the baby's head has broken, or maybe your baby is not super well applied to your pelvis, and so there's just lots of water being able to rush out around it. But if the water breaks up a little bit higher near your baby's feet, if your baby is well engaged in the pelvis, sometimes it's just a little trickle, and you're like, crap, I don't know what that was. There could be a multitude of things that it could be, right? We have more vaginal discharge at the end of our pregnancy, so sometimes that's going to trickle out. Sometimes we pee ourselves towards the end of pregnancy. Sometimes maybe we've had sex and unprotected sex with our partner because we're already pregnant. You don't have to worry about that. We're hoping that those prostaglandins in semen will get things started, and what goes in must come out. So sometimes we have a little trickle of semen coming out. What you're going to do if you don't know that you're ruptured is you're going to call your provider, and you're going to either go into the hospital or go into the office for an examination where they can test the pH of that fluid, see if it's basic. So semen, blood, and amniotic fluid are basic, or see if it's acidic. Urine and vaginal discharge tend to be acidic. And then from there, if it's not super obvious, they can also look at the fluid under a microscope and see what that fluid is showing them. So if it's amniotic fluid, it'll look beautiful like a fern. If it's semen, we're gonna see those little swimmers doing their thing. So we'll help you figure out if your water's broken if you don't know. I just had a patient come in the last time I worked, and it was her third baby, and she's like, I don't know if my water broke. So an experienced person might not know if their water broke. I didn't know if my water broke initially. So, but some things that can kind of give you a clue. Amniotic fluid tends to smell salty or sweet. Amniotic fluid also will continue to come out if there's any changes in pressure or if the baby moves position. So if baby does a big movement and you have continual leakage, or if you cough, have a contraction, and you have some continual leakage, that's a good sign that it could be amniotic fluid, but not guaranteed. So come to the experts, we'll help you figure it out, and don't feel ashamed if you didn't know, because not everybody knows all the time if their water's broken. We definitely want to make sure we know when your water's broken, because if it's broken for several days before labor starts, there is risk of developing an infection. So we just want to kind of keep our eyes on you and any signs or symptoms of infection once your water has broken. So the next one that is actually probably the most important one that I want you guys to know on this list, that I hear time and time again, is that your baby's movements slow down as you get close to your due date because your baby is running out of room and so they're not moving as much. This is not true, and this is dangerous misinformation, because if you have decreased fetal movements, you're doing your kick counts, and we'll go over that in a little bit, what you need to be doing, and you have decreased fetal movement, you need to contact your provider, and more than likely they will have you come into the hospital for a non-stress test. Most of the time, everything's on the up and up. Everything's totally fine, no big deal. But in the rare chance that it's not, we want to catch things early before we go from decreased fetal movement to no fetal movement and the possibility of losing your baby. And I know this sounds very dramatic, but it's really important that you know. So what do we want to do when we're talking about kick counts? So this is going to start in your third trimester, so at 28 weeks. What you want to do is periodically throughout the day, some people recommend once, some people recommend twice a day, but at a time when you normally feel baby moving, you want to sit down and be like, oh, okay, I felt a kick. And then in the next 2 hours, you want to feel 10 kicks, movements, flutters. If you're not feeling those movements in like the first hour, I recommend going and lying on your left side, drinking something cold and sugary to see if you can get baby moving. If in that 2 hours you're not feeling those movements, you want to give your provider a call. Most people are going to feel those movements in about 30 minutes to an hour, but it can take sometimes up to 2 hours because babies do have sleep cycles. Now, the important thing is that you're doing these at around the same time every day, so you know what's normal, and if there is a deviation or a variation from normal, I want you to contact your provider. Okay, if anything feels off. I feel like this saying like, oh, it's normal, your baby's running out of space, they're moving less, is a way to kind of take away your gut feeling that something is wrong. So if your gut feeling is something is wrong, if your kick counts aren't adding up the way that they normally do, call your provider. I would rather somebody come in 100 times and it not be a big deal than for them to be like, oh, I don't want to trouble someone, and then for them not to come in and it ends up being a big deal. So we always want to see you do your kick counts, talk with your provider about what they recommend as far as kick counts for you. So another thing that I think people think is quite common is cephalopelvic disproportion, which is when the baby's head is too big to fit through your pelvis, and that this can be diagnosed before birth. Well, one, we know that it can't. In my last video, I talked about how we think about people having birthing hips and that, oh, she's got birthing hips, she's gonna have no problem pushing out her baby. Well, first of all, the outside of the pelvis is not what needs to push out a baby, it's the inside, but also the inside of the pelvis has joints and ligaments that are mobile and flexible. So we can change the shape of the pelvis by helping you to change positions by you listening to those intuitive movements that your body makes during labor, one. But two, most of the time when a baby, there's arrest of dilation, which means you stop dilating, or there's an arrest of descent, meaning like you're pushing and you are trying everything and you are giving it your all and you're trying to push baby down, and it's not happening as we would expect. It is not necessarily because that baby was too big to fit through your pelvis or your pelvis was too small. It's that that baby in that position was too big. So our ideal position when it's time for baby to be pushing and coming out is in an LOA position, meaning that baby is in the left occipitus anterior position. So the back of their head is facing the front, slightly tilted to the left, and that their chin is tucked to their chest. This gives us our smallest diameter to come through. If your baby is not tucked, whoa, that's a way bigger diameter. Or if they're even flexed the wrong way, that's a bigger diameter. Also, if they're malpositioned in such a way that they're flexed, that maybe they're coming down in an OP or sunny side up, meaning that they're facing forward instead of facing towards the back, those can all cause issues with the fetal heart rate tracing because of the vagus nerve and how the vagus nerve is being pressed by their head being flexed. The vagus nerve runs down the back of the head. So these are all reasons why we might see fetal heart rate changes and we might have a baby that does not fit through the pelvis. So really working with your provider, with your nurse, with your doula, and with your natural body's movements, we want to work to get baby in the best position possible, both prior to birth and then during birth, so that they have the best chance of fitting through your pelvis. That is kind of the whole guise of a lot of different, like spinning babies, working with a pelvic floor physical therapist. All of those things are with the goal of helping baby get in the best position possible. I have several videos on prodromal labor and different movements in labor that I will link about getting baby into the best position possible. But it's frustrating, I know, when you have worked and given it your all and baby is coming down in a wonky position and you're unable to fix it. But all you can do is give it your all. And sometimes we can't get babies to change position, but often we can with strategic position changes in labor. Another one that I hear time and time again from even my coworkers at work is that if you have red hair, that you are more likely to have a postpartum hemorrhage. Now, there's not a ton of research on this, particularly with postpartum hemorrhage, but there is a little bit of research with surgical bleeding or post-operative bleeding. One study that I looked at was when you have your tonsils out. And there's really no correlation between having red hair and bleeding more. Maybe we'll find with research in the future that this is true, but it's not true based on the research that's present. Now, there is one thing that redheads do that is proven by research. Redheads need more anesthesia. They need more anesthesia to keep them comfortable and to keep them asleep, especially when they're going under general anesthesia. And this is just because of the genetic mutation that causes red hair also affects how their body processes anesthesia. So this is one of those things that was anecdotally true, but there was no research and has been proven by research, which is pretty crazy. Another one that is a common myth that has been studied and is not proven to be true, although anecdotally you will hear otherwise from any nurse anywhere, is that more babies are born on a full moon. I think the thought process was like the moon affects the tides, right, coming in and coming out, and maybe a full moon would affect the tides of your water breaking. And if you ask any nurse, shit hits the fan during a full moon, although maybe we're just noticing it more. But the research does not support this at all. There are not more babies born during the full moon, even though I will swear up and down that it causes some crazy things to happen. Now, one thing that is true is that a drop in barometric pressure does tend to put people into labor. When we have a big storm front coming in, anything like that, we will tend to see more people come in with their membranes ruptured, not necessarily in labor, but with their membranes ruptured in the process of going into labor. So I thought that was interesting. But full moon, studies show no, but my heart shows yes. So another myth that really I think a lot of us just don't even think about is that your delivery is over as soon as you deliver your baby. But you still have to deliver another organ. An organ that is going to be similarly sized to your baby, although thankfully, praise the Lord, has no bones. And this is your placenta. Now, there are two different ways that your placenta might be delivered. One is active management and one is expectant management. Now, they used to always do active management where your provider would gently put some traction on the cord to help encourage that placenta to be delivered faster because they believe that that would reduce postpartum hemorrhage or postpartum bleeding. That hasn't really found to be the case. So a lot of providers now are a little bit more hands-off. We let the placenta come when it comes, but you will more than likely have to do a little push, a little something to get the placenta out, even if it's just sitting in that lower uterine cavity, not still attached to anything. And then after your placenta is out in the hospital, it's pretty standard to give IV Pitocin. And you're thinking, whoa, wait, Pitocin? No, ma'am. No, thank you. I have already had contractions and I do not want to have any more. But fortunately, just like your natural oxytocin, which Pitocin is the synthetic version of, happens after delivery and causes uterine contractions to still happen, they're not nearly as painful as labor contractions because they're not contracting around anything. There's no baby that's being forced out. Now, if it's not your first baby, you might notice that these afterbirth contractions can be pretty uncomfortable, particularly when you're breastfeeding and your body is releasing a lot more oxytocin. But in general, postpartum Pitocin does a good job at reducing our risk of postpartum hemorrhage and not increasing pain significantly like Pitocin would during labor. Another one that I hear quite common postpartum when I'm asking patients if they've ever had any leaking of colostrum during their pregnancy, if they say no, they're always very, very, very concerned. Like, oh, I haven't had any leaking. Like, should I be worried that I don't have milk? And like 9.5 times out of 10, I'm like, you should not be worried. And can I show you your milk? Can I hand express a little bit of milk for you? And I'm able to hand express some milk for them. When you're hand expressing milk, you're gonna be about an inch back from the nipple. You wanna push back and squeeze together gently. It's really about what's back behind. It's not about the nipple. And if you do that right now, if you're pregnant, you might even express a little bit of colostrum, because we start developing colostrum at about 16, 17 weeks into our pregnancy. And for some people, yes, they leak. They leak all day long. They've been leaking for weeks and weeks and weeks. Collect that milk if you can, because it's just going to waste if you're leaking and leaking. Some people will hand express towards the end of pregnancy. I have an Instagram post about that if you want to check it out, because they want to harvest milk for immediately after birth. If there's any issues, they have that extra milk, and maybe they're also trying to get themselves to go into labor. It didn't work. But if you don't leak, that's okay. Leaking breast milk, or if you leak during pregnancy or postpartum, actually has more to do with the tone of your nipples than it does with the amount of milk that you have. Now, what you should be seeing during pregnancy is breast changes. Your breasts should get bigger and change in size. That way you might see more veining, you might see a darkening and a size change in your areola, because it kind of is serving as a bullseye for baby, who really mostly see in black and white to be like, hey, this right here is where we want you to be. If you're not seeing breast changes in pregnancy, I recommend before you deliver to seek out guidance from an IBCLC, an international board certified lactation consultant, to just make a plan if we are having any issues, if we're showing signs that maybe we do have insufficient glandular tissue. That is a possibility if you don't see any breast changes at all during pregnancy. But if you see some breast changes, if you're not leaking colostrum, that's a-okay. It does not mean that you're not going to have enough milk. So I know people always get really scared when I ask them that question, like it's a test question. And it's not. I'm just curious, and mostly I just want to show you that you have milk, because I think that that is amazing to see when you're like, oh, is baby getting enough? I'm like, let me show you the milk that you got. This colostrum, this is liquid gold, and we could sell this to bodybuilders. True story, they pay a bunch for that, but let's give it to our babies instead. And then the last two that I want to talk about are related to epidurals. They kind of go together. So once you get an epidural, you can't move, you have to push out your baby on your back. Not true, not true, not true. Once you get an epidural, my job actually becomes harder, because before you were intuitively moving and doing your thing. Now I have to figure out, based on where the baby is in your pelvis and the position that your baby's in, what positions I would like to help you move into, because hopefully you're still gonna have a little bit of movement that are gonna best facilitate your baby getting in that really good position to fit through your pelvis and opening the pelvis at the right location for baby to fit through. It's a bit of a puzzle and it's kind of a challenge, and I honestly love that. I love position changes. They're my favorite. We're gonna be using the peanut ball. We're gonna be using the bed. If you have any movement on your legs, I'm gonna still get you in that hands and knees position, because that does wonders. Open knee, chest, hands and knees. If we've got a baby who needs to flip, who is in that OP position and needs to flip, we are gonna change your position. We're gonna keep moving. And even better yet, you do not have to deliver on your back with an epidural. You can deliver squatting. You can deliver hands and knees if you've got some movement in your legs. And even if you don't have some movement in your legs, you can deliver on your side. That's going to reduce our risk of tearing. If it feels good to push on your back and deliver on your back, by all means do it. Do what works, do what feels good. But if that doesn't feel good and that doesn't feel right, you do not have to. And you can say, hey, I would like to try out a different position. I'm not going to deliver on my back. Stand up for yourself, be an advocate, have your partner and your nurse have your back, because you don't have to if you don't want to. The other one that I want to talk about is timing of an epidural, and does getting an epidural slow down labor? It just depends on when you get it. If you're in true active labor, an epidural should not slow down labor. And sometimes if you are having a really hard time relaxing during contractions, getting that epidural at that right time, when you know baby's in a good position, when you've been moving and grooving and doing everything, and you're like, hey, this has gone from pain to suffering, and I would like an epidural because I cannot relax, and that tension is making things hurt worse, and it's also stopping me from dilating as quickly as I could. That epidural and being able to relax allows that cervix to open, and all of a sudden it's time to push and have a baby. So Epidurals can potentially slow down labor if you get them super, super early, but you're the one experiencing pain. You're the one who knows what's best for your body. So in general, epidurals do not slow down the overall length of labor, although they can make pushing last a little bit longer. It's what studies show us. So epidurals are not bad. Epidurals are not evil. Epidurals are a wonderful tool that we can use to help you bring your baby here safely earthside. I love a good epidural. I love a good unmedicated birth. I love a good cesarean birth where you feel like you are well informed of all of your choices and you're making the choice that's best for you and your baby and their safety in the moment. I just love birth. I love having babies. Let's go have a baby. Definitely, if you have heard of any other myths, leave them down below so we can bust them together. And definitely, if you learned anything, let me know. I would love to hear that. And again, shameless plug, like, comment, subscribe, share if you want to. Simply watching this was fabulous, especially if you watch till the end, because I am out of that YouTube algorithm now because I've been gone for a while, but I'm back. Bye guys.